Hello, my name is Nicole Frazier, and today I'm going to be giving you the complete learning experience on how to manage a maternal postpartum hemorrhage. This training is designated for labor and delivery nurses who may have or have not experienced a hemorrhage, and just to keep up those clinical skills that are so important in knowing how to manage situations that don't happen on a unit very often. Through the combination of lecture, skill stations, and simulation, this will be a hands-on interactive experience. They'll be teaching strategies that will be used to address the cognitive, affective, and psychomotor domain of learning. Using all of these facets will ensure that the student nurses that are in this training will have the opportunity to really absorb the material. One, through hearing it, second, from actually practicing in skill stations, and then bringing it all together with all team members in an actual postpartum hemorrhage with a high fidelity mannequin. At the end of this learning experience, nursing staff will be able to verbalize risk factors for postpartum hemorrhage, demonstrate how to complete fundal assessments, verbalize correct dosage and routes of medications used in management of postpartum hemorrhage, and demonstrate correct nursing interventions to assist provider with bedside management. Let me introduce to you a patient named Michelle. She's a 34-year-old Gravida 4 Para 2. She presented to labor and delivery in active labor that progressed rapidly from 5 to 7 centimeters, which at that time she received an epidural. This patient had an unremarkable health history and was accompanied by her spouse. She went on to deliver a 9-pound, 2-ounce baby boy, APGARs of 9.9. After delivery, the midwife waited patiently for the placenta to separate from the uterine wall. As time went on, taking over 20 minutes, the midwife called the OB doctor to the room for evaluation. As the placenta is still not spontaneously removing from the uterine wall, the provider decided to manually remove the placenta. After removal was complete, the placenta did appear that it was intact, and the fundal assessment was firm at the umbilicus with minimal bleeding. Over the course of the next 45 minutes, the patient experienced bonding with her infant, skin to skin, initiated breastfeeding, and all of the other normal joys of bringing a new life into the world. It was during her fourth fundal assessment that the nurse noticed a boggy uterus, and clots began to express with heavy bleeding as she provided fundal assessments and rubbing. The nurse hit the call light for the provider room and alerted staff that the patient was experiencing a postpartum hemorrhage. The nurse calmly explained to the patient that she was experiencing too much bleeding and that hemorrhaging was taking place, and asked the father to take the infant off of mom and sit in a corner. They were instructed that in a minute the room would be filled with many people, and this was for her safety. Providers, additional nurses, technicians, lab, pharmacy all arrived to the room, and this was where the chaos seemed to begin. There was a recorder assigned. No charge nurse was available for assistance, but many nurses were involved with medical administration, and equipment was not working as designed. The OB provider finally called for silence in the room so that they could review what medications had been given and where we were in controlling her bleeding. It was at that time that the fundus started to firm up and remain firm. The next step would have been to head to the operating room. This was my first experience with a postpartum hemorrhage, one that I felt overwhelmed by and that I would never forget. And today I plan to explain to you why learning how to manage a postpartum hemorrhage, staying calm, and working as a team is so important to the outcome of a patient's bleeding. So, what is a postpartum hemorrhage? The American College of Obstetricians and Gynecologists define a postpartum hemorrhage as a blood loss of 1,000 milliliters or more within 24 hours after birth and up to 12 weeks postpartum. This life-threatening emergency is a leading cause of maternal deaths. Because blood loss from a postpartum hemorrhage is difficult to accurately assess, it is often underestimated. Treatment is based on clinical signs and symptoms and mode of delivery, with main goal of stopping the bleed. In October 2017, the American College of Obstetricians and Gynecologists, ACOG, updated their recommendations on evaluation, prevention, and management of postpartum hemorrhage. Risk factors include the most common, uterine atony, along with retained placenta, lacerations of the birth canal, uterine rupture, placenta accreta, maternal blood disorders, uterine inversions, and infection. Women can be identified on an admission as low, medium, or high risk based on clinical factors. These factors can change over the course of labor and birth. Prevention is focused on active management of the third stage of labor, including IV medications, uterine massage, and umbilical cord traction. These risk factors can also be remembered by remembering our 4 T's: tone, trauma, tissue, and thrombosis. Active management of third stage of labor. An assumption exists that any woman who gives birth in any hospital in the United States will have access to blood products and other basic life-saving therapies, and that these hospitals will have an adequate number of highly skilled clinicians, which include nurses, doctors, midwives, who can reliably recognize, respond, and manage an obstetric hemorrhage. Components of current active management of third stage of labor, depending on the source, include the routine administration of prophylactic uterotonic just before, with, or immediately after birth, early cord clamping, controlled cord traction, and uterine massage. So follow me in the event of a postpartum delivery. Our midwife will deliver the infant, and typically the infant goes directly on mother's abdomen. The provider will wait usually about a minute for the cord to stop pulsating, then offer the dad to cut the cord. Once the cord is clamped and cut, mom begins to lift baby up towards her breast. She looks at the baby, she thinks of her baby, and those hormones, oxytocin, are released. At that time, oxytocin begins to contract the uterus. It is also at that time that nursing staff will start to administer Pitocin through the IV. Pitocin, being the synthetic form of oxytocin, also does the same job of causing uterine contractions. As that uterus contracts, the placenta gently separates from the uterine wall. In the case of Michelle, her placenta didn't automatically remove from the uterine wall and required manual removal. But in a normal delivery, what we're used to is that it will spontaneously remove. Once the placenta spontaneously is removed, bleeding will occur. Expected blood loss is anywhere from about 50 mLs to about 300 mLs. There are times when those blood vessels don't clamp with that uterine massage and heavy bleeding continues. That's typically where we'll experience uterine atony. With fundal massage and the use of Pitocin postpartum, all of these things together will cause the uterus to contract, stay firm, and therefore constricting those blood vessels and allowing there to just be minimal blood loss. That's what we expect. Once a postpartum hemorrhage is identified and you have staff members come to the room for assistance, your provider will order medications. Typically, the first medication of choice is going to be Pitocin. Pitocin being the synthetic form of oxytocin that your body normally produces. It's typically given in doses of 10 to 40 units added to a 1-liter bag of normal saline or lactated ringers and is infused rapidly. It's important to remember that dosage of this medication can cause hypertension and water intoxication, mainly because of the amount of fluid that is also administered with each unit. The second drug of choice is usually Cytotec, which can be given as 800 to 1,000 micrograms. This is typically given in a route rectally. This can cause elevated temperatures, shivering, and diarrhea. Third medication is Methergin. It's important to remember to avoid this medication with hypertensive patients. It's given in a dose of 0.2 milligrams intramuscularly. The fourth medication is Hemabate, which it is also important to remember to not give with asthmatic patients. It can cause diarrhea, fever, and tachycardia, and is given in a dose of 0.25 milligrams IM. The last medication we have been starting to give with more postpartum hemorrhages as the final medication is tranexamic acid. We call it TXA. That's given in a 1 gram dose, and it's given as an IV piggyback. If medication and fundal massage don't seem to be stopping the bleed, there is a use of medical device. A Bakary balloon is a silicone obstetrical balloon specifically designed to treat postpartum hemorrhage. This device is used to temporarily control or reduce a postpartum hemorrhage when conservative management of uterine bleeding is warranted. The last resort would be to go to the operating room. Depending on the cause of the bleed, repair of cervical lacerations or the complete removal of the uterus through a hysterectomy may be warranted to control the bleed as a last resort. Nursing interventions continue. We'll want to insert a Foley catheter, identify a recorder for all the events going on, obtain an ultrasound, have it in the room ready for the provider. After we've identified where the hemorrhage is coming from, an ultrasound may be used to see if there are any additional products remain in the uterus or if any fluid is noted there. We want to administer oxygen, have that ready, and that will also help as far as with the patient's level of consciousness. We'll want to obtain a Bakary balloon and have that ready for insertion, and then always have your OR staff on standby. Simulation, when learning how to manage a postpartum hemorrhage, is imperative for a unit on labor and delivery. The Joint Commission on Accreditation of Healthcare has recently addressed the management of maternal hemorrhage and stated clinical drills to enhance the management of this emergency should be performed. Simulation training in obstetrics is a relatively new field that holds great potential for improving patient care. This is such a great idea because with the use of high fidelity mannequins, we can incorporate all the skills we would use on a live patient without providing any harm to the patient. So it's a very safe way to hone in on those skills that are needed in such critical emergency situations ahead of time. At this time, we'll break out into skill stations. We'll focus on medication administration, making sure that we have the right route, we have the right dose, and also important things like making sure we're checking allergies and correct patient at time of an emergency. We want to make sure we understand on how to pull up medications from vials or IV bags, or even how to mix medications, such as our TXA that comes in a powdered form that needs to be mixed in fluid. We'll also at this time learn how to assist the provider with a Bakri balloon insertion. It's very important that nurses know how to accurately and quickly inflate these balloons, as it's very critical performance and step in managing a postpartum hemorrhage bleed. Our training will conclude with a complete simulation to simulate a postpartum hemorrhage. Our training will include a high-fidelity simulation mannequin that will display everything that we would see normally with a regular human being during a postpartum hemorrhage. Our nursing staff will have to rapidly identify what's going on, assess the patient to include vital signs, blood loss, call the appropriate providers to the room, anticipate what will happen next. So this is also used as an assessment tool to ensure everything that was explained today is absorbed by the staff nurse. We'll focus on things like team dynamics, closed loop communication, role assignments, documentation, and the importance of debriefing after every obstetric emergency. This concludes our training for today. Thank you for your time.